information to. So yes, it was just to sort of discuss the importance of the system as a whole, consisting of different parts and with different frequencies of function. And so yeah, it's really a discussion to see what are the different factors that can contribute to our clinical reasoning when choosing tests, and really to answer the question that's being asked in the referral.
So,
This was
would
the
you
main
would you
reason
rather
for
we ask
sharing.
questions at the end, or shall we interrupt you with questions? What would you prefer?
I think questions at the end would be better, so that
Fair
we
enough.
can, because obviously there's a fair bit to cover, and if there's anything
No, that's perfect. Go ahead. Thanks.
at the end, is that
I had
okay?
to ask. Yeah, that's fine. I had to ask. That's all. Yeah. Go ahead. Go ahead.
Okay. All right. So yeah. So good evening, everyone. And today's discussion will just give us an opportunity to address in vestibular testing, particularly in a case of Meniere's disease. You can go to the next one, yeah. So this was a case of a 34-year-old female who was diagnosed with Meniere's disease in the right ear. She was treated with intratympanic steroids initially, which seemed to work quite well for her. Sorry, I think there's someone hasn't muted their microphones.
That might be me.
Okay. So yeah, so she was treated with some intratympanic steroids initially, which seemed to work quite well for her. But a few days before the referral, she started experiencing episodes of spinning with some intermittent dizziness, which wasn't always movement related, and tinnitus in the right ear as well. So she had no other relevant health conditions. There was no BPPV, no migraine, no other vestibular conditions apart from Meniere's, which was diagnosed. Her MRI scans were clear, and due to the recurrence of the symptoms, vestibular neurectomy was being considered. And so vestibular neurectomy is done to cut off a portion of the vestibular part of the vestibular cochlear nerve, whilst preserving the hearing part of the nerve. So this would preserve hearing in the right ear, but eliminate vestibular input from the right vestibular organ. And we know the permanent nature of such a surgery. So before going ahead with surgery, there was a need to ensure that there was good balance function on the left side, the good side. So this patient was referred to us for balance testing, vestibular testing. However, only VNG and calorics was requested for. Next one, yeah. So the patient was not under any vestibular medication in the 48 hours before testing, yeah, just to let you know. So the test results were as follows. Tympanometry showed bilateral peaked with normal middle ear function. Reflexes were present in both ears. Next. Audiometry showed obviously in the right moderate low frequency sensory neural hearing loss, and the left was within normal limits. Next. So VNG testing did not show anything of significance. As you can see, values for saccade, smooth pursuit, gaze testing with and without fixation, optokinetic. Now, I apologize, I could not add the results for all of the VNG tests. I've just added a few here. Next, please. Now, caloric testing indicated bilateral hyperfunction, as can be seen in the low peak slow phase velocity values, which are as low as 0.9 and 0.7 degrees per second in the right, and 1.4 and 2.1 degrees per second in the left. Now, obviously, disregard the CP and DP values here, because it should not be taken into account when the individual ear values are this low. So now, based on caloric testing, we see bilateral hypofunction, but the patient did not report any oscillopsia. She could walk without support. She didn't complain of unsteadiness whilst walking or standing. Her performance on a balance board, which we had done initially just to get a sense of her subjective balance function, was not consistent with the diagnosis of bilateral hyperfunction. And her dizziness was not always movement related. So I decided to test further. Next. Now, rotatory chair also indicated bilateral reduced function on the basis of the time constants, which were below 10 seconds. Next. CWEMP was absent in the right ear but present in the left. Next. And V-hit indicated normal gain in all 6 canals with overt saccades on rightward head movement. So here we're not seeing a true bilateral hyperfunction. We see that we've done 3 canal function, out of which just one is showing bilateral hyperfunction. So why are we seeing a sort of a discrepancy between these tests? Next, yeah. Okay. So could it be a central vestibular disorder? However, imaging was clear, as mentioned on the reports, and VNG did not show anything of significance. Bilateral Meniere's disease, as you know, it has been reported in some studies, as you can see here. However, unlikely because CVEMP was present in the left and the hearing test results were within normal limits in the left ear as well. And bilateral hyperfunction was ruled out by V-hit testing. So next, please. Yeah. So let's discuss the discrepancy between these tests for lateral semicircular canal function. But just to sort of remember, these tests check for different. So the caloric test is a low frequency test which assesses function in the lateral semicircular canal in the low frequency range. That's 0.003 to 0.03 hertz. Rotatory chair assesses function in the low to mid frequency range of 0.01 to 0.0, so zero point 0.6 actually. And V-hit tests function at a high frequency range of 1 to 6. Yeah. Next. Now, we have 2 types of hair cells in the vestibular organ. Okay, so that's type 1 hair cells and type 2 hair cells. Now, type 1 hair cells are known as high frequency afferents, responsible for detecting high frequency movement. And type 2 hair cells are known as low frequency afferents, detecting or responsible for detecting low frequency movements. Now, studies suggest that in the early stages of Meniere's, the type 2 hair cells, which are situated in the peripheries of the ampulla, are affected first, while the in the central part of the ampulla might be affected later as the disease progresses. Which is why calorics, which tests for low frequency type 2 hair cells, indicates a loss of function, but not V-hit, which checks for or which tests for type 1 high frequency hair cell function. Another theory is that the fluid mechanics, because of endolymphatic hydrops, can affect the convection currents whilst testing calorics. But this is not seen in V-hit because the mechanism of testing with V-hit is not the same as calorics. So now this provides us with some answers as to why we see different results on different tests. But why would we see a hyperfunction on the other good side as well? So that's next now. So just to discuss the process of central compensation, which could provide us with some answers. So central compensation is the process by which the cerebellum restores function on the affected side so as to reduce the asymmetry within the peripheral balance system, which in turn reduces the dizziness that one experiences after vestibular insult. Now, one of the mechanisms that the cerebellum uses for central compensation is called cerebellar clamping, which is discussed in literature. Now, clamping is when the cerebellum temporarily reduces the function on the good side while it restores function on the affected side. Now, as function is restored on the affected side, it releases the clamp on the good side. So during this clamping stage, we could see reduced function on both sides during testing. Now, literature suggests that if function is reduced significantly on the affected side after unilateral insult, The clamp on the good side could be particularly strong, but should resolve quickly. So in this case, since we only see reduced function, the type 2 hair cells on one side, the clamp could be applied to type 2 hair cell function only on the other side. On the What we see here is um, that we're seeing this reduced function only on calorics, because obviously that's the one that's testing type 2 hair cell function on both sides, but not on VHIT. Now, the same authors also suggest that the phenomenon is usually seen only in the low frequencies. However, I have seen this in high frequency tests as well. When we test patients in the acute stages of vestibular neuritis with VHIT, when the gain on the affected side is sort of below zero point 0.4, I have seen gain on the contralateral good side to be sort of borderline abnormal. So about say 0.76 with some reduced over the saccades. But when repeating these tests in about 2 or 3 weeks, I've seen the gain on the good side go back to normal, that's above zero point 0.8, with no significant saccades. In our case, we did not call the patient back to repeat calorics to check whether function was restored on the good side, which is what I would have liked to do. But obviously, with calorics, it's more challenging to repeat the test because it's less tolerated. So we don't generally repeat it unless required. All right, and the next one. So the takeaway points here are just, the fact that it's advisable to treat the balance system as a system of many small parts with different operating frequencies. So it's important to test all the parts and frequencies to get a good sense of the function of the system as a whole. This will avoid misdiagnosis and help with management. Now, in our case, if I'd relied only on caloric testing, I would have misled the referring consultant to think, and the patient to think, that this was a case of bilateral hyperfunction, which has less of a hopeful prognosis. Between tests which check for function in the same organ in Meniere's disease. But this is not the only pattern that we see. It's one of the patterns. There are other patterns as well, but obviously it would depend on the stage of the disease when testing. So yeah, so that was just a short sort of presentation on this particular case.
Okay, so that's fantastic, and I really appreciate the way you've gone into the minutiae of the investigations. So, Arun, now this is up to you. Do you want me to fire some questions and expose my own ignorance, or would you like to be the wise man of Ispahan?
Well, I think, listen, the one thing I wanted to say, but I might hand over to you just after that, is the standard practice, whenever we get a result which is not expected, is to repeat. And that's one thing I've consistently and regularly sort of advocated. I appreciate it might not be necessarily have been possible in this particular case, but for whatever reason, there can be, a million and one things that can go wrong with a particular test. So I would certainly, I think you did the right thing by treating the patient, not the test. But yes, it would be nice to repeat the test.
Okay. So anyway, I'll give you a lot of opportunities to give us your experience, because from my side, I'm not really giving any gyan. I'm sort of getting some points clarified. Uh, do you all do any testing, something like the good old glycerol test and Lasix furosemide testing to see whether the ear is still functioning before you resort to surgery? Wade, you could take it, or either of you. I'll leave it here.
I'll come back and I'll let Ved answer it so that he can say what, because of course I'm not a surgeon. I very much as come from a medical perspective, even though my previous background is surgery. I'll let Ved answer it because he might do something different where he's based.
So if you could repeat the question, Dr. Nair, because you broke a bit.
So that's I'm based on my experience when I used to be a little more aggressive as a surgeon. We would be very cautious about doing surgery if we were able to demonstrate that the patient's hearing would fluctuate with using doing the glycerol test, for instance, where you reduce the osmolality of the inner ear fluids and show some degree of functionality still present in the organs before you go ahead and do any section. That's how we used to use it as a rule of thumb. Do you all still
Mhm.
follow that practice, or do you all go ahead anyway and do the neurectomies?
So, in terms of the glycerol test, we don't do the glycerol test here. Um, the question about whether more testing or whether we could repeat testing, obviously, like I said, I would have repeated the test, but in this case, it's calorics. But sort of the ENT, the consultant didn't sort of refer the patient back. They didn't. I think they were happy with our sort of um, interpretation of the tests, and so they were happy with knowing that there's function on the other side, and so neurectomy was possible on the side that was affected. That's the right side, but we don't do glycerol testing. No.
Okay, so my second question is, do you feel the patient was adequately treated with only steroids, or do you feel some form of medication would have been indicated?
I think beta histine would have been good to try. Now I'll let Dr. Arun sort of answer this question because it's more medication related. But I guess beta histine might have been the sort of thing to try after neurectomy because obviously it helps with compensation, with central compensation.
No, I mean before or after. I mean, I'm just trying to say, can we avoid doing drastic procedures? And my last
In this,
question is, how
yeah,
frequently do you resort to neurectomies?
I'll let Dr. Arun answer that one because
So, Arun, you have three arrows thrown at you. Number
Well,
one is
let me go.
withdrawal. Sorry, go ahead.
Let me work backward because it's kind of clear in my head. So first question is, as far as I'm is how often do we do neurectomies? I'll be honest, in the last 10 years, I haven't seen a neurectomy, certainly in the London patch, only because it is considered relatively old-fashioned, and in fact, more and more, the last person who I dare say is an expert in the field, who's done lots of research, collected huge amounts of data, is now subclassifying all the Meniere's into autoimmune and autoinflammatory subtypes. And firmly believes that it will be purely a medical treatment going forward once the technology and all of the other sort of associated evidence base improves. So I haven't seen any.
He would be gray haired like me by now.
He's a very wise man, we should say, like yourself.
Unlike me. Go
So
on. Yeah.
that's number one. Number one. So I haven't seen a neurectomy around the London area for a long time. Number two, yes, beta histine. And to answer the question, we use beta histine aggressively, and that's the only indication for any condition, as far as I'm concerned, to use beta histine for Meniere's disease. Now, and the third question was about whether we use any of the sort of glycerol tests and things. But the answer is no, only because it's been superseded by sort of more up-to-date imaging and imaging techniques. And actually going back to sort of Ved, he might be able to answer this. Did the patient have any MRI imaging, firstly, to exclude other disorders? And number two, did they have any specialist MRI imaging? Because that's our sort of latest go-to, which will determine whether there's disease evidence on the other side or not, regardless of the vestibular function, because as you may know, vestibular function could be preserved at the early stages. So, the question is, has he had any of the standard MRI or specialist MRI imaging?
So there weren't any details provided to us about the MRI scans. All we had in the referral was that MRI scans were done and imaging was clear, and they were happy with the fact there was no central indication there. So
Okay,
there was
fine.
no details. Yeah.
So the latest, just to sort of take up on the latest evidence base, is about doing a specialist MRI scan, which involves double dose contrast and waiting for it to trickle into the inner ear. And that way, we've been able to pick up early contralateral disease, which is not apparent in either on audiometry or on vestibular testing. So that seems to be the way forward when it comes to determining whether this is working or whether the contralateral side or not is affected reliably.
Mhm.
So I have another general question here. At least my experience, limited though it may be, I don't put much stock by the caloric tests. I have often found the caloric tests are non-contributory, especially if they're bilaterally symmetrical. It may or may not mean anything. It may not mean that there's anything abnormal, because I find the caloric test is a pretty vague test physiologically, because you're relying on the canal skin to cool the brain, to cool the to set up convection currents, which is, 3 hits away from the main organ. So your take on that?
Ved, did you want to answer that, or shall I? Why don't you answer it first, and I'll also sort of follow it up.
You can be critical.
Yeah, so with the
I'm just
caloric test,
giving you some. Mhm.
yeah, I mean, see, with the caloric test, it's obviously we're testing the patient at a non-physiological frequency, and that's why it's less tolerated as well. So it's not a go-to test. So when I test, I always start with VHIT, and then I do VEMPs, and then I go on to VNG, and then I do the chair. I keep calorics for last. Now the thing with calorics is that it's still sort of really sensitive to even small differences in function. So if all testing is sort of normal, then I will still do the caloric test, because I still feel that in some cases, even if the patient is feels a bit dizzy on movement, and all the other tests have been normal, sometimes I could get just the caloric test as being affected, even if it's a 20% difference or a 20% asymmetry. And I mean, it's known to be gold standard for, still is, and so yeah, I mean, I still include it in my test battery, but I don't always do it, especially of course if VHIT is already giving me answers, and even if the chair is giving me answers, then I will not then do calorics.
And when you do calorics, you do the whole cold, warm, or do you do bithermal, or do you do any other kind of just?
So I'll start with, obviously I'll start with monothermal calorics, just as a screening. If it's quite symmetrical, and we have a protocol here where if it's less than 15% the asymmetry, then we don't need to move on to the cools. We can stop there.
Do you do bilateral warm, bilateral cold? What's your monothermal?
So I start with bilateral warm, yeah, and then I check if there's a difference of more than 15, and if there is, then I move on to cools.
So I mean, I quite honestly confess, though it's nice and time consuming, and the patient loves it, getting a bath. But I'm a bit of a caloric skeptic. Arjun,
So
what's your take?
I think I take a sort of middle ground, because sort of going back to Ved's earlier point, in Meniere's disease, there's this clear discrepancy between the VHIT result and the caloric result. Whilst actually in your case, there was some VHIT positivity on that right-hand side. We have lots of cases where VHIT would be completely normal, and the only results which may be abnormal is the caloric test. So in that case, it adds to the diagnosis. Now, but at the same time, let's say if all the other tests were negative, would I rely upon a unilateral canal rhesus on a caloric? The answer is no. And also, our cutoffs tend to be a lot higher. So unless it's at 30% or 35% asymmetry, we wouldn't really sit there and think that'll be the main cause of the patient's symptoms, and we'll be attributing that to potentially other causes, because the rest of the vestibular system is pretty intact. One of the questions I wanted to ask, Ved, is that do you guys do any frequency tuning as part of your event protocol? Because that, again, can add another layer of evidence to support Meniere's in one side or the other side.
Yeah,
And
absolutely.
do you know what I mean by, yeah?
Yeah, so absolutely. So with CVEMP, we would have done a frequency tuning, but we didn't do it for this patient.
Okay.
Also,
What frequencies do you normally use?
500 hertz. Obviously, check with 500 hertz first, but then move upwards to 1 kilohertz, and then
Okay.
2.
So yeah, compare the ratios. Yeah.
Yeah. But the thing with what, going back to what you said about calorics as well, I know that you wouldn't necessarily necessarily rely on that one result that's sort of asymmetrical if it was, say, 21% or something. But
Yes.
I think we're also missing out on particularly some more information from the otoliths, which is doing a low frequency otolith test, and that's something that is not practiced very commonly, like doing a sort of a video ocular counter roll or something like that for the otoliths in the low frequencies, just to see if the calorics and the low frequency otolith function tests, like the ocular counter roll, if there would be a sort of a similarity there, and which is something that I don't do. I don't do an ocular counter roll, so I don't have information from the low frequencies from the otolith organs. Yeah. So I'm just wondering.
I think. Yeah, no, I certainly don't pay too much attention to a unilateral deficit, especially a borderline deficit, only because there's a lot more to the balance system than the inner ear. And I think that's the sort of key take-home message here, because I do think that there can be lots of other reasons why the patient can be dizzy, can be off balance. And yes, there may be an asymmetry in the vestibular system, but is it enough to basically, let's say, for example, have them all constantly off balance when the rest of the vestibular system, which is actually quite resolute, is providing enough information? So which is why I do think we should be looking for other causes as well when in those kind of similar cases where there is a deficit, but a borderline deficit. There's also a question there from Sunny.
Hello. Good evening. I'm from India. So, sir, actually, I wanted to know, like, when the patient was having the symptom of vertigo and spinning sensations, like whether it was a chronic history or more like an 1 or 2 years of history, because the audiogram still is in the rising pattern and we are seeing a evident vestibular hyperfunction. And when do we generally see in many cases like the hyperfunction is like permanent in nature?
So in case of this patient, in terms of how long she's been having these symptoms for, was for a year. And then she was, like I said, she was being treated with the steroids, which seemed to have worked initially. But then she had this recurrence of episodes of spinning. And the recurrence of episodes was about a week before we tested her again.
So I think, and I'll answer the second part. I think it's about, is there a permanent deficit of the vestibular system? Well, I've seen hearing recover in a fair few, many years cases. I haven't seen the vestibular system recover so much. So it seems to be less, I guess, prone to recovery if there is a vestibular deficit that's identified on testing. And I think in Ved's case, it's definitely obvious, at least on the V-hit, and definitely on the caloric with, it's so bilateral, didn't it? So it's a bit harder to determine just on the calorics. But V-hit, certainly there was a clear deficit on one side.
Yes.
And what about the VEMP? Again, that was down as well, was it? On that right side?
It was absent.
It was down on the right. What's happening?
Yeah. So it's definitely, I mean, I haven't seen that recover, unfortunately.
So,
but
sir,
of course, the brain is very good at compensating.
Yes.
Sorry, go ahead.
In your experience, sir, like usually how many, like we can be quantified by number of episodes or by the history of the chronicity of the disease? When do we see permanent hyperfunction? Like in first or 1 or 2 episodes, we might see a recovery in function also. Because I'm just starting in vertigo. I'm very
of course, I think. Well, listen. The sooner you can, I think that if you're starting, I don't offer any promises. I think that's the one thing that always comes back and bites us. Number one, and everyone's slightly different. Number two, I would say it's very difficult to predict. I don't think anyone's quantified when the vestibular hypofunction occurs or when the auditory dysfunction occurs and whether they're correlated with each other. But what we have seen is, based on the experience, is that a lot of the cases where we've been doing imaging and there's evidence of high drops, it can affect either the cochlea or the vestibular system or both. And in which cases, that can give us an idea as to which system is affected first. But as I mentioned, lo and behold, with lots of the vestibular ones, we haven't seen significant recovery. Whilst with the hearing ones, we can sometimes rescue the low frequency hearing loss with aggressive treatment. fact, I have a lovely audiogram of a lady who had a moderate reverse sloping hearing loss, a moderate to severe, completely normal now and discharged, all on medications.
Was that on beta histine?
It was a combination of high-dose steroids, beta histine, and there's some evidence for diuretics. So I think we were quite aggressive with her at the beginning, stabilized her and came off everything.
Sir, you prefer beta histine only during episodes or till symptoms last, or do you continue it for longer durations?
So regular, and it's so beta histine is very much a preventative drug. So for Meniere's disease, we're trying to reduce the buildup of endolymphatic hydrops within the vestibular and the cochlear systems. So you have to take it 3 times a day. You have to take it at the higher doses. So your standard dose might be 16. I tend to go up to sort of 48 3 times a day. And I will continue until, I'm satisfied that there's no further residual disease fluctuation, shall we say. So absolutely, you have to take it regularly. For acute episodes, you can try symptomatic treatment like prochlorperazine and antiemetics.
So when would you resort to surgery or referral to a neurosurgeon or otoneurologist?
We haven't recently, because most cases we've managed with a combination of drugs and intratympanic steroids.
Do you
So
feel
when
there's
would
any
I?
role for sac decompression?
I think the evidence currently is that it's a very destructive kind of disease, and the cases where, for example, surgical, destructive therapy is considered, is the next step would be intratympanic gentamicin injections if they have lots of
I'm
vestibular
talking about
symptoms.
sac decompression.
I know, but as in that would be the only sort of what I'm trying to, I guess, imply is that would be the worst case scenario for me, intratympanic gentamicin. Sac decompression is not even in my list of things I've required anyway, not recently. Of course, I'm sure many people have irreversible cases.
I'm going to pull rank on you. The way things go around, I think it'll come back. So
I'm sure it will. I'm sure there'll always be some sort of case. So there's only one patient I've ever referred for canal plugging because we couldn't fix their BPPV. It kept coming back. So there's always a case. There'll always be a case. So never say never to any option.
So, Ved, could you just expand a little, because I think that's a good take home for everybody, about the various frequencies and the tests specifically to various frequencies.
Yeah, so when it comes to the different frequencies, so we know that the lateral semicircular canal, you can test it with at different frequencies, and the spectrum, you've got the caloric test, and that's at a frequency range of 0.003 to 0.03. Then you've got the sort of low to mid frequency range where you can do the rotatory chair test, and that's about, say, 0.03 to 0.6, that kind of range. And that's a range from 1 hertz. So this is obviously our movements, the movements that we perform in everyday life. The most common ones are the high frequency types, which are tested by VHIT, and that's why it's a more commonly used test. And we also see that recovery or compensation happens more readily or more easily at these high frequencies because we're making these movements all the time. And we usually tend to see that at the mid and the low frequencies, compensation takes a bit longer. Yeah. And so that's the kind of, those are the multi-frequencies that I would test.
I think there was a question from Abdul Musawir
we have the
Sorry, there was a question from Abdul Musawir. I think I saw it on the chat and then I couldn't track it anymore. Our friend from Pakistan had a question.
Let me just have a look. Do you prescribe MAOB inhibitors when beta histine is given? No, I haven't routinely prescribed any sort of additional I might
You
have
got
lost
on
you.
mute. Yeah.
Oh, did I
Yeah.
go on mute? Which part did you hear? I was just reading the chat, and I'm not sure if you heard the question.
The question was
Hello?
regarding MAO inhibitors, right?
That's correct, yes. In
Right.
addition to the beta histine, I think is the question. And I think, no, not recently. I know there used to be a trend, a phase at one stage where we were, using MAOB inhibitors, but we haven't, there hasn't been much more evidence base for it, and we haven't particularly pursued that, certainly not recently. So at the moment, it's beta histine, and occasionally bentriflumethamide.
Could we ask him what is the Pakistan protocol, if we may know him? Is he online? Could you just Abdul? Hello.
Hello.
Yeah.
I haven't used it, but I have read an article from Michael Strupp, and he has done some studies and a 2-phase trial, I think.
Yeah.
Second trial was done, and he has used saligeline or rezagiline, I think so. Saligeline, Celgene, that is the trade name from GSK here in Pakistan.
Correct.
But I haven't used. So I was just trying to confirm, should it be used to increase bioavailability of beta histine?
No, I think a higher dose seems to work a lot better. So do not hesitate to ramp up to 48 milligrams 3 times a day if required. Of course, check with the patient the tolerability. So the MAOB inhibitors are a group of drugs which, obviously, for those who don't know, it's used for Parkinson's disease and things.
Yeah,
I think maybe the side effect. Yeah, maybe the side effect profile.
Of Parkinson's disease.
Correct. Yeah.
Basically, they are anti-Parkinson. They are used with levodopa or carbidopa.
Correct. But I'm not sure there was convincing evidence that it helped significantly in the Meniere's populations. And of course, it comes with its own side effect profile. So it never took on.
Okay, thank you.
And most neurotropic drugs have a lot of side effects, which Hello, can you hear me?
Yes, we can hear you.
Yeah, so I said most of the neuro drugs do have side effects, which I don't think we as ENTs use them frequently enough to see the side effects. But if we do, we'd be a little more cautious, I think.
I think it also, you can, sorry, I was going to say, you can actually, we're used to using a lot of it, as I said, now my practice is predominantly more medical, but it can be mitigated against by using the right protocols and the right drug and the right sort of titration protocols. So that's experience. That's right. Talking of which, Paul Radomski is here, the leader of the person who invented we're talking about the frequency responses of the vestibular system. And Paul is probably the person who drew that up in the first place and described it. And he's here with me at a course, and he just walked in.
Oh, good. Get him on
screen. He says hello. So we get him on screen. If you mind, Paul, would you mind saying hello very quickly? So hang on. You can have maybe try speaking. Yeah. This is Paul Radomski. He's an international vestibular specialist and probably one of the leaders in vestibular testing in the field.
Yep.
Okay.
Very privileged to work with Paul there.
With a ski, does he land up in England or from Poland or from where?
He's of Ukrainian and Italian heritage. So I think after the course, so we're currently in a pediatric vestibular course. After the course, I suspect we'll be in an Italian restaurant with a glass of vino.
So let's hear from him. Could he tell us?
Oh, he's unfortunately just he's running in between things, so he had to leave for. He's one of the organizers of the pediatric vestibular course here. But he's certainly described the multi-frequency response of the vestibular system very nicely. He's certainly one who converted me to that idea, and it is very much true, because when we test it, each one of our vestibular tests have their own limitations. And Paul had a very nice slide earlier, which is where we sort of say, how much do we actually believe each vestibular test? And the answer is, even for calorics, I think the number was around sort of 56%, which is the highest in terms of yield when it comes to vestibular testing, whilst all the other ones tend to be even lower than that. So we have to do a battery. We have to think about a multi-frequency approach, and we have to then also interpret it in clinical light, I think is Paul's, take-home messages, I'm sure, if I speak on his behalf.
So I open the floor for other questioners, other people. Ahmed Eldamati from, I assume he's somewhere from the Middle East. Would you like to pitch in with your questions and your concept of a protocol or questions specifically to the speakers? Anybody? Divya Martin, Shweta? So let's do a quick recap. Basically, what you have given us is a rather meticulous analysis of a patient who came with uh, a test which suggested a bilaterality of disease, which was of concern because surgery was planned on one side. So you went into the explanations as to why you could have a bilateral abdominal test, though the problem was unilateral. Would that be a fair summary of your presentation?
Yep, absolutely. Yep, I think that's spot on. And yeah, and the importance of
go on. Importance of
yep, and the importance of doing multi-frequency and testing the vestibular system as a whole to get a good sense of function of the system as a whole, like we do with hearing tests. So we check different frequencies. I think it's important to also use the same logic with balance testing or vestibular testing as well.
So I mean, I now have a few sort of questions to in general, which is how often, and Arun, you could take that also. How often do you repeat these testings if the patient reports benefit? Meaning, what is the
Benefit
correlation between the tests and the patient's clinical, improvement?
Is that from the Meniere's perspective or from general perspective?
Let's stick to Meniere's for the time being, because many times you say patient improved, but nobody really cares to show that in terms of any testing. Yeah, and that's been my observation. I don't know.
I think it's sort of going back to that earlier question, at least if I answer that first, just to clarify, if there is a vestibular dysfunction, it's a permanent vestibular dysfunction. Vestibular dysfunction doesn't cause episodic symptoms necessarily, but it basically does affect your underlying overall, balance. So that can be compensated and rehabilitated. So it doesn't necessarily leave any sort of, I guess, longer term deficit. So from a Meniere's perspective, the main thing we'll be going for is the symptoms. Is the patient necessarily symptomatically improved? Are they getting less vertigo attacks? Is their hearing not fluctuating as much? Are they getting less tinnitus and less oral fullness? Those would be the criteria. The only objective measure which I use is the hearing levels, because I think that's a lot more sensitive to the activity of the disease, and the vestibular tests, which are too insensitive, shall we say, in my opinion. I don't know what you think, Ved.
No, I see your logic. I mean, I think once damaged, it tends to remain damaged in that sense. So your testing, repeat testing is not going to show anything. But then would you have problems? Would you care to do, the balance estimations in cases of Meniere's? Because to expect that only the rotatory function or rotatory aspect of the inner ear has gone would be a little far-fetched. I'm sure there would be some abnormality in the utricle and saccule too, and therefore you would have some issues with balance. I don't know how frequently do you do general balance testing in these patients?
From my perspective, all the time. So, clinical assessment of balance. I don't necessarily do any objective assessment all the time, because that's another story. But Ved, do you guys do objective assessment of the balance as a whole when you do see vestibular testing. So do you do, for example, posturography or any clinical physiotherapy like assessments like what's it called, stand and go type of tests?
So the stand and go type of tests, or I would do only if I were to see a patient with true bilateral hyperfunction. And we have it as a protocol here, especially when we're fitting the balance belt. That's a different discussion, really, but it's kind of a treatment method that we use for bilateral hyperfunction when the patient cannot rely on any vestibular inputs. But as a routine, we don't use standard timed up and go. The sort of more regularly when sort of measuring outcomes for rehab. And hello, can you hear me?
Yeah, we can hear you. So what about the CVEMP, OVEMP, those kind of tests?
So with CVEMP and OVEMP, I wouldn't necessarily repeat those as outcome measures. I think the main test that I would do as an outcome measure would be VHIT with rehab, because that gives you a measure of the amount of compensation that has occurred. I look at the saccades a lot, and the gain also sometimes does sort of change the gaze more towards one. But the main thing I would look at are the sort of the spread of the saccades, the overt saccades, and the amplitude. So that's something that I use routinely as a measure of outcome when sort of seeing patients for rehab, so soon after testing.
So as a ballpark, how often is your VHIT abnormal in mean years?
Ballpark, well, it's difficult to say, really. I mean, this was a rare case. I mean, this is probably, I've seen 2 more cases like this, but in general, I do see VHIT affected, and it would be gain affected as well. So with saccades. So I can't give you a ballpark, but I would say most of them would have VHIT affected as well.
Is that your experience, Arun?
I think it depends on the stage of the disease, because maybe we're lucky.
Yeah.
Some of the ones we see are relatively early, and by that time, calorics are definitely affected, but we get lots of normal VHITs. So I almost find by the time that VHIT is affected, it started affecting all the other frequencies. So it depends on the stage of the disease is the answer. Early disease, calorics only. Late disease, VHIT also.
Yeah.
So
That's something
we are entering the. Sorry, is there a question from somebody? No. So
No.
we are entering the fag end. Just some general questions. How frequent in general is mean years now, as opposed to when you started your practice?
There's a question. It depends if it's the diagnosis of Meniere's versus the actual incidence of Meniere's. The actual incidence of Meniere's has not changed, but the diagnosis of Meniere's has used to be very high, and now it's very low. So, well, the true answer is it's probably somewhere in between, isn't it? So, but the fact is, the incidence hasn't changed. It's still one amongst the rarer of conditions, but at the same time, it's there. And it is something to keep an eye out for, but not to overdiagnose or underdiagnose it.
So what do you think is the main benefit of all these courses which you conduct?
Sorry,
there's a googly here. What do you think is the main plus point of all these courses we conduct?
What do you mean? Courses as in like educational?
No, yeah, on Vertigo, there are a lot of workshops and so on and so forth. What do you see as the positive takeaway from a trainee's points of view?
Oh, I see. Well, I think let's be clear. I mean, in terms of the pre-graduate or undergraduate training of Vertigo, it's extremely poor. Majority of the development in this field has only happened in the last 10-15 years. Postgraduate training is key to really, and particularly in Vertigo, to come up to date with these ongoing rapid changes within the field. and things are constantly changing. So absolutely, it's it's essential, vital, and it'll stop us from making the wrong diagnosis and getting sued.
NICE guidelines, have they changed a lot since the beginning?
So we don't have NICE guidelines when it comes to vestibular disorders, and forgive me if I'm wrong, but I never seen NICE guidelines for vestibular testing or disorders. The majority of the guidance in the UK comes from for testing comes from the British Society of Audiology. The rest of it is all based on, and I think throughout the world is currently still based on expert consensus, on sometimes on Barani Society guidelines, and that's pretty much what we have. Little bits of evidence here and there. So unfortunately, there is still a long way for us to go.
Terminology at the Barani thing is vertiginous in itself. So I've always had problems with deciphering the Barani. I mean, I don't know whether y'all are better at it.
I think it gives a good guide to people to be able to at least think about it the right way.
Okay, fair enough.
It's not all encompassing.
Yeah. So there are a lot of loopholes. What do you think is the direction of research in Meniere's now?
So shall I give you the hot off the press? And hot off the press is not anything I'm doing, unfortunately, but certainly it's conversations I've had. And I think I touched upon this earlier. They are now subclassifying all the Meniere's types into 3 major groups, including autoimmune and genetic types. So that is the future direction of travel. There's lots of blood tests, additional blood tests that we can do, very much from a autoimmune type of perspective, and based on the phenotype or I guess the different subtypes, there might be future treatment options are also available, all medical rather than anything more exciting than that. So tablets and other things. But that's, as I said, it's work that's currently happening by sort of eminent people in this field. I'm sure it'll all come out in due time.
No problem. And as a sum up, give me a global perspective in your travels. Do you find Meniere's to be, or when you meet people in international conferences, what is the general take of Meniere's? Because there used to be a suspicion that it increases with urbanization. Does it still hold good?
No, I think to answer that, we have to. I don't think the incidence of Meniere's has changed in the population. It's remained stable, static. I think what has happened is that everything that used to be labeled as Meniere's is now no longer labeled as Meniere's, and we're now having the whole range of diagnosis. So I think this is where education really comes in useful, particularly postgraduate education, these scientific discussions that we're having, all of those things, because of course the main differential for Meniere's is vestibular migraine. You can think about other conditions like episodic ataxias, which can all present with episodic vertigo. There's lots of differential diagnoses now, which people are more aware of.
Fair enough. So now, last words, Dr. Furtado, you could pitch in with some take-home message for everybody. Not for Arun, of course, he's going out for a glass of wine and some Italian food, so you could leave him out of it. But I think the rest of the audience could.
Yeah, well, the take-home message is really what I've already spoken about. It's just sort of using the tests that are available to us to test the vestibular system to give consultants a good idea of what's happening. That's, as an audiologist, that would be my role. And I think the tests and the equipment available these days is really good, really accurate, and it gives us good information. So if we were to use this information with all these tests that are available to us, it will just help with management. So that's the main take-home message, really, from my point of view as an audiologist. Yeah.
Thank you. And Arun, your words of wisdom?
I think I agree, though. It's tests, if they are used correctly, if they're interpreted or performed accurately and interpreted in clinical light, I basically test all my patients for that reason, because they do add another layer of evidence and information. So 100%, I do think that it needs to be a holistic, combined process.
So that's great. I think I must thank you all, both Ved and Arun, for a brilliant exposition and
thank you, Ved. Yep.
suffering my questions, which are pushing you into all nooks and crannies of this complicated area. And thanks to all the audience who stayed with us and asked us questions. Thank you very much.
Thank you, everyone.
Given us food for thought. Now let's think about some food also.
Yeah.
Right.
Have a lovely evening, everyone.
Thanks,
Same
everyone.
to you. Thank you. Bye.
Yep.
Okay.
Take care.
Bye.
Bye-bye.